Hi there. So my name is Dr. Alihussein I Kassam, and I'm gonna check you down through the ESC 2018 guidelines for hypertension. This will be just a summary of the comprehensive guidelines, which can be easily accessible via the internet. So classification of hypertension remains more or less the same. As you can see, we have from optimal, which is systolic blood pressure of 120 and below, and diastolic pressure of 80. Coming to the high normal, which is 130 to 139 millimeters of mercury systolic, 85 to 89 diastolic. And then we have the grade 1, 2, 3, which are from 140 to 159, 160 to 179, and more than 180, being the systolic. And on the diastolic part, we have the similarly 90 to 99, 100 to 109, and more than 110. And this classification remains pretty much the same. And we have an isolated systolic hypertension, which is either a systolic hypertension of less than 140 millimeters of mercury and diastolic less than 90. So this classification enables us basically to know whom to screen at what time. If you have an optimal BP that is less than 120 to 80, you would like to screen that patient or person every 5 years. With a normal BP ranging from 120 to 129 and 80 to 84, then do it every 3 years. And with a high normal, and that's where most of the issues related to hypertension begin, you're advised to repeat the BP at least annually. If you have someone who has hypertension of 140 millimeters of mercury systolic and 90 diastolic, then you're advised to do repeated visits for office measurements, or you can have an out-of-office BP measurement by the ambulatory BP measurements. This is pretty much the categorization of a patient who comes with hypertension into degrees from low risk to very high risk. So as you can see, you have hypertension disease staging. You have stage 1, 2, and 3, and then you have number of risk factors, and then you have the grades. And based upon that, you can categorize BP and hypertension into either low risk to very high risk. One easy way of remembering this is anyone with CKD stage 4 or diabetes or with end organ damage is already a very high risk patient. Okay. And also a patient who has more than 3 risk factors, stage 1 complicated, is a high risk patient. So the common questions for all is, when do you start pharmacological treatment? So it is well understood that anyone with grade 2, so remember, we say that grade 2 hypertension begins from 160, okay, to 179 systolic blood pressure and 100 to 109 diastolic blood pressure, while grade 3 is more than 180 millimeters of mercury for systolic and 110 millimeters of mercury or greater in diastolic. So these patients should receive antihypertensive treatment for sure. Okay. Lifestyle modifications, on the other hand, goes to all patients, and this shouldn't be necessarily hypertensive, but it should be a routine to tell all patients that they require lifestyle modifications. So these are recommendations. So an easy way to remember this is that if you have a patient, okay, um, there are two categories of patients. One is a greater than 65 years old patient, and his target or her target would be a blood pressure of 130 to 139. Okay, and this is because they are geriatric patients and they can have adverse effects. They have polypharmacy and a lot of other issues. So their target is a little bit higher. Whilst for the young who are less than 65, the target accepted for systolic blood pressure is 120 to 129. Okay, so those are your targets for systolic blood pressure. What about the diastolic? The diastolic is a generalized target of less than 80 millimeters of mercury. So again, we have three targets, two for systolic, a range of 130 to 139 for patients above 65, a target of 120 to 129 for patients below 65, and a diastolic BP target of less than 80 for both patients. And how do you start? So always you start with one pill with dual combination. Always. The only exception is that if you have a patient who is at a very low risk, okay, grade 1 hypertension, you remember we saw the risk stratification, and the systolic is less than 150 millimeters of mercury, or in very old and elderly patients who are above 80, or frail patients, and this is the only time you'll use one pill with one drug. Otherwise, it's always a dual blockade, and it's always ACE or ARBs. You never combine the two. So again, here you have an ACE, okay, or ARB plus a calcium channel blocker or a diuretic. I can give you an example. An ACE or ARB can be either you have a combination of valsartan, a calcium channel blocker such as amlodipine, okay, or you can have telmisartan as an ARB and a combination of a diuretic such as hydrochlorothiazide, okay, so that is in some places marketed as TEL-EH. Step 2 is that when you have this and they don't meet your targets, you can go to, again, one pill and triple combination. So again, you have ACE or ARB, always, never combine them, plus a calcium channel blocker and a diuretic. So the three drugs in combination, okay? And these are usually to the max of their dose. And if they fail, then you can term this patient as a resistant hypertension, and then you can go to two pills with triple combinations. You have to check the serum potassium levels, okay, before adding a spironolactone, okay, to a level of either 25 to 50 milligrams per day. If not, then you can give a diuretic, an alpha blocker, or a beta blocker like metoprolol or bisoprolol. Remember, if you have any patients along this line, okay, that would have a beta blocker better or than one of the drugs. An example, in pregnancy, ACE inhibitors are contraindicated due to the teratogenic effects. It's better to give a beta blocker then, okay? And also remember, at this point in time, when you're entering a diagnosis of resistant hypertension, it's also better to consider referral to a specialist care facility. And this is because there might be other causes of the hypertension. Maybe there is a secondary cause of hypertension that can be screened and better found by a team of specialists. So again, this is the same logarithm. And this is just a summary of whatever I talked about. The main things being that never combine a RAS blockaders. That's the class 3A indication. And that summarizes our guidelines for ESC hypertension. There is a lot we can talk about in hypertension. This is just a tip of the iceberg, but it's great to start with in terms of managing hypertension. And I wish you all best of luck. Thank you.